Presenters are Dr. Didi Ray, Critical Care Planning Lead for Healthcare System Support at the New York City Department of Health and Mental Hygiene, Yeashea Braddock, Community Partner Engagement Lead for our Outbreak Response, and Nannette Blaize, our Race to Justice Program Coordinator. Please note that you have been placed in listen-only mode. If you have any questions during this presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. As a reminder, a PDF of these slides, as well as a recording of today's webinar, will be available on our webpage following today's presentation. We appreciate that you're busy doing important work and are grateful to you for choosing to spend part of your afternoon with us today. With that, I'll hand it over to Dr. Ray.
Hi, everyone. So as mentioned, I'm Dr. Madhury Ray. I'm the Critical Care Planning Lead right now for the COVID-19 response. And as usual in these presentations, I want to remind everyone that our understanding of SARS-CoV-2 and COVID-19 is evolving rapidly. The data in this presentation and the guidance in this presentation are up to date based on our knowledge as of April 23rd, that's yesterday at 5 p.m. And a brief outline of our presentation today. As always, we will update you on the current status of the outbreak. We'll give you a little bit on surveillance data and the current clinical findings, as well as some tips and current guidance. Then we are going to transition over to our colleagues Yeashea and Nannette, who will talk about health equity issues and initiatives amidst the pandemic. So I just want to highlight to everyone, as we've been saying for the last couple of weeks, there is still widespread community transmission of COVID-19 in New York City, around the world. It has been almost 2 months since we reported the first confirmed COVID-19 case in New York City. And although we are still seeing high numbers of new diagnoses, people who need hospitalization, we have begun to flatten the curve. So our syndromic data is showing improvements in emergency department visits and admissions for what we call COVID-like illness. And we'll show you that in a second. And the important message to take away from this is that we cannot let down our guard. We have to continue on the path that we've been going on successfully to reinforce mitigation measures that have started to work as we begin to transition into different phases of the pandemic. And so the following 2 slides are time series of syndromic surveillance data. And again, this is influenza-like illness and pneumonia, what we are sometimes calling COVID-like illness. This is the number of people who are visiting the emergency department per 100,000 of the population. And we have it separated into different age groups here. And as you can see, and as has been true throughout the pandemic, the visit rates are highest for those who are as age increases. Now, this is a little bit different. This is emergency department admissions per 100,000 population. And as you can see, the same pattern is holding true. We are seeing a decline across all age groups, but I would remind you that some of the data at the very end do change. So this brings up the question, when can physical distancing be relaxed? As we are thinking about that, we have a series of public health milestones with different indicators that will help us understand how ready our healthcare system is to handle and ease of restrictions. The restrictions, as we've said before, are not going to be eased all at once. They may be first eased for people not at high risk for COVID-19 illness. The 3 indicators we look at, and I really encourage you to use the link. The slides will be available after the talk at the bottom of the slide. The indicators we're following are hospital admissions, critical care capacity, and positive test rates. Right now, I am showing a slide that talks about the positive test rates. And we separate these out into testing done at the public health laboratory and testing done all across New York City. As many of you know, there are providers outside of the public health laboratory that are accepting tests. You can see that the percent positivity among tests that are done is decreasing. And for both public health laboratory testing and testing for all of New York City. Now, in terms of surveillance, we can see from the Johns Hopkins map cases around the world. You can still see that there are quite a few in North America. We have 2.7 million cases and over 190,000 deaths around the world as of yesterday. Within the US, you can see that our area is still lighting up around the country. In the country, we have over 860,000 cases and over 46,000 deaths. So in New York City, we have 141,754 laboratory confirmed cases. Of those, 36,723 are hospitalized. With deaths, we have, we separate the deaths into confirmed cases in which there is a COVID positive test prior to death, and probable cases where COVID likely death from COVID-19 is indicated on the death certificate. That's 10,290 confirmed, and over half of that number, 5,121, probable. We now have a map of COVID-19 cases based on the patient's address for different zip codes all around the city. And you can see a lot of zip codes in the Bronx, in Queens, and Brooklyn are still high. There are also some in Staten Island. We want to emphasize that these data are subject to what we call testing bias, which means that if you test more people because more people have access to healthcare in a certain geographic area, then more people may come up positive. To combat that, we have a second map here, which shows the percent of patients testing positive for COVID, the percent, I'm sorry, of patients testing positive for COVID-19. So this means even if more people are getting tested, even if they're not sick in a certain geographic area, in that case, the percentage will go down. And you can see that some of the zip codes in Staten Island where there were a higher number of tests that were positive, now the percentage of tests that are positive are not in the highest bracket. Here we have the cases, hospitalizations, and deaths in New York City. I would remind you not to pay too much attention to the very tail end of these curves, because the tail end of the curves are updated as we get more information. And the information lags behind the actual cases, hospitalizations, and deaths. So what you can see is that hospitalizations mirror cases, but that deaths, as you would expect, lag behind hospitalizations. That indicates that persons are in the hospital for some period before they pass away. We also have COVID-19 rates by borough, and these are, we have the hard count of cases in each borough over here under count. But what you can see is that some of the Queens, the area with the highest count, if you look at the number of positive cases per 100,000 of population, so relative to the number of people in that borough, the highest ranking borough is the Bronx with 2,168 cases per 100,000 people. You'll remember just a few minutes earlier, I mentioned the probable and confirmed deaths in COVID-19. And what we're seeing here is that the confirmed cases, that is persons who passed away after getting a positive COVID-19 test, are here in orange. And then above that, we have probable cases where the death certificate data indicates that they died from a COVID-like illness. And you can see that there are a large, relative to the number of confirmed deaths, there are a large number of probable deaths. Again, I would advise everyone that the end of the data is subject to bias from delays in reporting. And so don't pay too much attention to the data at the very end of the curve. What we can see is there is a little bit of a decrease or flattening from the peak of the curve. There are a lot of All right, apologies, everyone. The problem appears to have solved itself. Hopefully it will remain solved for the rest of the talk. So I think something that concerns a lot of providers is which underlying conditions may be associated with greater mortality in COVID-19. And so we have done this analysis. And so, as we expected, age is a very important underlying factor, even though age is not exactly directly correlated necessarily with every comorbidity. But with an underlying condition, we see that same pattern where those in the highest age group, the patients who are oldest, are suffering the most deaths. And you can see what the underlying conditions are listed here. Those are lung disease, asthma, heart disease, a weakened immune system, obesity, diabetes, kidney disease, liver disease, and cancer. All right, and we are also, which is very pertinent to our conversation and which we'll expand on a little more further in the talk, we're also reporting some race and ethnicity information among our confirmed cases. What you can see very clearly here is that in all groups, non-hospitalized, non-fatal hospitalized, and known to have died, the rate of COVID is higher in Black or African American populations and Hispanic Latino populations than it is in white or Asian populations. We do want to note, though, that these data are pretty incomplete because the collection of this data in for many of our cases, traditional electronic laboratory testing doesn't record ethnicity or race, but we're working to bring you better and more complete data on by race for COVID-19. Now we're going to get into some of our updated clinical information. I want to reference our health department health alert number 11. If you haven't looked at it, I suggest you do. There's a lot of really useful information in there. We're going to talk to speak to a question that we get a lot and that we're hearing a lot about, which is serology assays for SARS-CoV-2. And basically, with these tests, we don't understand exactly what they mean for immunity. We don't understand what having, what these tests tell us is that you have a particular antibody against SARS-CoV-2. It doesn't tell us whether you're immune, whether you're capable of getting the disease, whether you're capable of passing on the disease. And so you'll see this note from our health alert that these serologic tests should not be used to diagnose acute or prior SARS-CoV-2 infection, nor to determine immune status to SARS-CoV-2. We also want to bring up the fact that many of the tests, the antibody tests out there, are unvalidated. They're not validated by any independent government agency, including the FDA, and that the sensitivities, specificities, and predictive values for these kits, meaning anything that you could use a test result coming out of this kit for, is it's not validated, and we can't vouch for that accuracy. Again, the National Societies, the Infectious Disease Society of America, strongly cautions that antibody testing should not be used as a sole source of diagnosis or assumptions regarding immunity. In terms of testing, though, we want to update you that the Public Health Lab is now accepting both nasal swabs and saliva for COVID-19 testing. This is in addition to previously accepted specimens. For both of these tests, we are asking that you use synthetic fiber swabs with a plastic shaft. Flocked swabs are preferred. Dacron or rayon and synthetic fiber swabs are also acceptable, but calcium alginate swabs, cotton swabs, or swabs with wooden shafts will not be accepted if you send them to the Public Health Lab. We are at the Public Health Lab, we are only offering testing to hospitalized patients with acute lower respiratory illness consistent with COVID-19. And to get approval, you can call our coronavirus testing call center via the provider access line that you use day to day. That number again is 866-692-3641. I want to update you on face mask and face covering policies. So in order to prevent asymptomatic transmission, all healthcare facility staff should wear a face mask regardless of the type of setting or service being provided. And your healthcare facility will give you some guidance on which type of face mask to wear when. For all New Yorkers, if outside the home and you can't maintain a physical distance of 6 feet, wear a face covering. That's a well-secured paper or cloth that covers your mouth and nose. I can tell you there are 5 people in this room and all of our faces are covered. And now we want to give you a quick update about a topic you may have heard about in the New York Times or various other newspapers. For those of you who are in the ICU or have colleagues in the ICU that you're talking to, you may have heard a lot about acute kidney injury and COVID-19. And acute kidney injury, also called acute renal failure or acute renal insufficiency, is an abrupt reduction in kidney function. So this is different than chronic or subacute kidney injury. This happens over hours to days. And this is something that we're actually seeing an unprecedented amount of in COVID-19, which is a little bit out of the norm within the disaster literature. And, part of the reason this took us by surprise in US and Europe is that early studies of cases in China suggested a low percentage of patients who developed acute kidney injury. And stage 2 or 3 acute kidney injury, which is the worst acute kidney injury that you might need. You might need to treat directly with, with dialysis or some other sort of extracorporeal therapy, has been reported in about 30% of ICU patients in some centers. Some institutions anecdotally on webinars have talked about 50%. So this is a very large number of ICUs that are already over full. And then we have 5% of patients hospitalized in 2 centers in New York City did require new renal replacement therapy. And this is, this acute kidney injury, as I said, it's new and it's a little bit unexpected. And so these data are from populations in China where the disease looks different. But what we do seem to know about this acute kidney injury is that it's serious and it is associated with a higher risk of death. We have a risk of 31% versus 9%. And this is true for acute kidney injury in any case, whether it's COVID-19 or not. But that what we're worried about here is that this high level of kidney impairment in COVID-19 may overwhelm hospital capacity for dialysis and going forward, the care of those patients. And this slide actually just talks a little bit more about the higher mortality risk with patients in COVID-19. And then what we are trying to discover is how this higher mortality risk in COVID-19 relates to the higher mortality risk of acute kidney injury otherwise. The authors of this paper do suggest monitoring kidney function for all patients, regardless of past disease history, especially when you are suspecting COVID-19, and to consider interventions to prevent the development of acute kidney injury in patients with severe COVID-19. I'm going to talk a little bit, since I said this is a new area, about the mechanism of kidney injury in COVID-19. And the answer to what causes this is we don't know. There are several theories, and we have a lot of good sources that you can look at if you are interested in this issue that are in the slides, which will be available after the presentation. I'm going to talk to you about a couple of them. Those are viral infection, thrombosis, cytokine storm-induced injury, and treatment modalities. And as we, as in everything when we're investigating, it is always possible that more than one of these mechanisms is contributing to acute kidney injury. So one of the most intriguing possibilities is possible viral injury to kidneys in COVID-19. And you may have heard about ACE2 receptors and TMPRSS. So these are receptors that the SARS-CoV-2 virus uses to enter cells. And ACE2 receptors are found in different areas of the kidney, but they're found specifically in podocytes and proximal tubules. Oops, sorry. I'm going to go back 2 slides. So, and I think we don't have the slide here, but there is an autopsy series from China of 26 patients who developed kidney injury, and they have some great pictures of actual viral inclusions within podocyte cells. So it seems like even if this is not the primary cause of acute kidney injury in COVID-19, it is certainly an important one. Kidney thrombosis. So we have seen significant coagulopathies in COVID-19, and part of this impacts perhaps the etiology of this disease, but also the treatment. Patients who are placed on continuous renal replacement therapy or intermittent dialysis are subject to clotting of the circuits in a way, and even clotting of dialysis filters in a way that we don't commonly see. And there is a lot of interesting literature on coagulopathy in COVID-19 that I encourage you to check out. But the point is that thromboses in the kidneys may actually be affecting kidney function, and that same series of 26, that same autopsy series of 26 patients in China did show microthrombi in the kidneys. Finally, I think that, we've been talking for a long time about the cytokine storm, or in severe COVID-19 patients who are very sick, that there is a lot of immune-mediated injury throughout the body, and it is quite probable and quite possible that that cytokine injury is what is part of the is one of the contributors to kidney dysfunction. And then finally, which this is a topic that I thought was quite interesting, is that are we causing some of the kidney injury in these patients? And so I'm discussing I have listed here two different aspects of treatment that we initially thought were, the best possible treatment, but may be impacting other organs. And this is, part of our innovation and our learning around, well, presented with this new disease. And one of the possibilities is that high PEEP mechanical ventilation, that's high positive end expiratory pressure, which is standard for treating ARDS, which is the lung syndrome that we see in a lot of COVID patients who become very ill, can also does also create high intra-abdominal pressure. And this, for a number of reasons that we can suspect, but we don't understand completely, contributes to decreased renal function. Additionally, the guidelines, consistent with a lung disease and lung injury, suggested really, really conservative fluid resuscitation to protect the lungs. And however, many of these patients have fevers, many of them have had GI distress, and so it's easy to underestimate the amount of insensible fluid loss that these patients have had when they're coming in. And this running these patients very, very dry may actually result in a pre-renal injury. And the last piece that I'm going to talk about will really bring us very well into the next half of our presentation. And I'm going to talk a little bit about race and minority and its impact on COVID-19 epidemiology in New York City. We know that all over the US, Black people are hospitalized and dying at disproportionately higher rates from COVID-19. This is, part of what we call the social determinants of health. These social and historical and structural factors are all contributing to what we're seeing in the epidemiology. We also want to say that we are in this paper by Dyer, which is cited at the bottom of the presentation, which again will be available after the presentation. He wants to note that other communities where it's harder to measure data around them, right, and harder to include them in our epidemiological studies, what he's calling invisible communities, are also probably suffering disproportionately. We just have a hard time measuring it and seeing it in our data. And we're specifically calling out from this paper US Indigenous peoples and underdocumented immigrants. One of the things that we wanted to address is something that we've heard popularly, or a common narrative that we've encountered, that these communities are not worried about COVID-19. By these I mean the ones that are starred, which is Black, Hispanic, and lower income communities, are just simply not worried about COVID-19, and this is just a behavioral issue. And a survey from the Pew Research Center looked at the concern that people have by income and race about COVID-19. And we can see that this narrative doesn't appear to be immediately true, and it's certainly not supported by the Pew data. So you can see that Black, Hispanic, and lower income persons who answered this survey are likelier to say they are very concerned about getting COVID-19 and requiring hospitalization. And also, you know, if we think about compliance with physical distancing, very, very concerned, are very likely to be concerned that they might unknowingly spread COVID-19 to others. We're also highlighting paper an opinion paper that came out in JAMA on April 15th, which talks about the social determinants of health and COVID-19. The article is titled "Failing Another Stress Test on Health Disparities." And we, you know, the issues that are brought up in this paper that are relevant to COVID-19 and really impact how an individual or a group might fare during this pandemic are the same kinds of social determinants of health that we think about every day when we think about provision of healthcare and public health. And those are living in poverty, cramped apartments, access to healthy food, having to take public transportation when unable to work, working frontline jobs under hazardous conditions, and of course, the limited access to PPE that goes along with that. We have biological factors that we knew before COVID-19 were significant in individual health. And then they've listed some further contributing influences, both on the patient side and the provider side. And of course, these are all, you know, this systemic look may help us understand the disparities in infection and outcome in COVID-19. So what do we do about it? And I think that part of it is understand it better, and the other part is directly try to address the issue. And the authors recommended 2 immediate actions. One of them was to mandate data collection of COVID-19 cases stratified by race, ethnicity, sex, socioeconomic status, and community health status. And, you know, as we discussed in the electronic lab test collection system, we are going to have to, if we are to implement this, we're going to have to think about how we collect our data. The other suggestion is multilingual, multimedia public service announcement campaign targeting minority populations. And again, this is the other half of that. We have to collect the data, and then we have to tailor our response according to that. And then with that, I'm just going to remind you of the resources from the New York City Health Department. We have them listed here. There is a specific provider page, a data page. These weekly webinars are Fridays at 2 p.m. You can sign up on the provider page. We have Dear Colleague newsletters, which you can sign up for a subscription on the website. You can also look at the previous letters. And finally, our excellent, they are my favorite reading material, New York City Health Alert Network notifications. We have the link here to sign up. And I know this says questions, but I'm actually going to pass this off to my colleagues, and we're going to take all the questions at the end. Thank you so much.
Oh, God. What did I do? Oh, God. Well, now I know what I did. Didn't work.
Good afternoon, everyone. My name is Yeashea Braddock. I am the Community Partner Engagement Deputy Lead, and I'm part of the Community Partner Engagement Unit here at the Department of Health in New York City. And I am sitting here with my colleague, Nannette Blaize, who is also part of our unit, and she is our Emergency Partner Engagement and Council Coordinator, and also a Race to Justice Coordinator here in the Department of Health. And so we're just going to jump back in from where Dr. Ray left off, talking about the impacts of disparities and racism on New York City and the COVID-19 response. So the key points that we're going to really talk about today are poor outcomes are concentrated in certain geographic communities. And as Dr. Ray pointed out, it's usually poor communities and communities of color. And what we have learned is that these disparities are further exacerbated during emergencies, and that the root causes of the disparities that we see during emergencies in particular directly correlates to structural racism and other forms of oppression that exist in New York City and in our nation. And most importantly, that we as a city and a city agency and providers, we have to work together to address these issues through interventions, modality shifts in thinking, and really getting at these root causes to really change outcomes for all populations across the city. And so we're going to talk about our own internal New York Health Department's racial equity and social justice framework. We're going to talk about how that connects to emergency preparedness and response. And then we're going to talk about the community partner engagement and the COVID-19 response. So what we are doing to actively address and mitigate the disparities that have been highlighted during this presentation and throughout the course of this response. So I'm going to shift over to Nannette.
Hi, everyone. As Yeashea just stated, Race to Justice is the agency's initiative designed to really embed racial and social justice lens into the work that we're doing every day. And what we really focus on is health equity. And that's really the attainment of the highest level of health for all people. And a lot of what was mentioned today basically are the health inequities, which are the differences that we see in health outcomes that are rooted in the social and structural injustices that are prevalent. And often when I'm in a lot of these spaces, what we talk about usually are health disparities. So the ways that we're measuring progress or lack of in a lot of cases to try to address the health inequities. Okay, so here you can see just a little snapshot of what it is that we do in our day-to-day. Building staff awareness and skills through trainings, discussions, learning labs, and other methods of contact. We actively work to examine the impact of structural racism and other systems of oppression. And we are really working on strengthening collaborations with New York City communities. And then you can see our little design here, which is racial justice, social justice, and gender justice. We'll get to a little bit more information about that down the line. So here's a snapshot of what health equity looks like. It's pretty self-explanatory. When we usually talk about racism or issues around social oppression, it's always the word equality. And equality is not the same thing as equity, as we can see. So equity is about meeting the needs of people individually where they are and helping them by allowing them to self-determine what their needs are, what services and other things they might need to improve their own health outcomes. So what creates racial inequities in health? And we see some of the dominant narratives that we hear a lot about. Oftentimes when patients come in or we go to communities, a lot of the conversation is around personal choices, information that we learn about genetics that's been taught over time that is racist. And in reality, those are not the things that drive racial inequities in health, its policies, its bias, social factors. And now we're moving to root causes. So when we talk about racism at the health department, what we're starting to do and trying to do is to acknowledge that racism is a system of power and oppression that structures opportunities and assigns value based on race, and it unfairly disadvantages people of color while unfairly advantaging people who are white. And I know this is going to be up for debate. A lot of people have questions about that, but that really is what racism is and what it does. So you can see the ticker here. Racial prejudice plus power equals racism. And there are different forms. So internalized racism, that's operating on a psychological level within individuals. There are unconscious or conscious or unconscious beliefs about ourselves and others based on race. So this is something that a Black person or a person of color can exhibit. Interpersonal is the most common form. It occurs between people. If someone goes to the office and is trying to receive care, and either they don't want to be seen by a provider because that provider is a Black person or a person of color, or the provider makes assumptions about that person based upon the race, and there's an interaction, that is an interpersonal form of racism, and the most common that we hear about. Institutional occurs on the level of institution. This is where policies, practices, and systems within the institutions create and sustain the racialized outcomes. So what we try to do in Race to Justice is to get people to take a really closer look at what types of policies and practices they're putting into place that may be perpetuating the poor outcomes that we're seeing in our community. And structural. Structural is the massive, it's the behemoth of all of this. It's what flows through all of the institutions and really undergirds our society. And it's what we're trying to, in this small way, try to address. It's a system of structures, institutions, and policies that work together to advantage white people and disadvantage people of color. So when we're talking also, a lot of the trainings people like to do are about implicit and explicit biases. So basically, the brain can't effectively process all of the information, so we take mental shortcuts. And the biases that we see operating often, they're on a subconscious level, and we're not even aware that we have them. And this also can happen in a lot of places where people are like, I'm not racist, that's not me. And you might not really be, but because of the way our society functions due to structural racism, we receive messaging constantly about people, what their attitudes are, and how they should be treated. And that informs a lot of how we show up in our workspaces and in our professions. So whether you realize it or not, you can in fact be exhibiting racist behavior, even if that's not what your stated belief or what your attitude or value system is. And this happens at an individual and institutional level. So what about emergencies? Well, we're in an emergency now, and we see what's happening. Emergencies magnify inequities facing communities every day. So if you're a member or a person of a community that's traditionally marginalized, for example, Black people right now, we see what's happening in terms of how we're receiving treatment or maybe not. And what that means now when, as healthcare providers, you're put into a situation where you have to make snap judgments about who gets and receives care. And I'm giving it back to you.
Thank you, Nannette. And so when we think about who are the groups that experience inequities during emergencies, as you can see, this list is no surprise. It's the same communities and people who experience inequities on a daily basis in our city and in our country. So I'm not going to read the whole list, but it's a really long one. And I'm sure you as providers are experiencing that as well, and know that this is what's happening. And so why it's so important here at the Department of Health to apply an equitable approach is because we really want to be able to leverage resources more effectively by focusing on those populations who are suffering the most and most impacted by sort of any emergency, and specifically, obviously, COVID-19. And if we do this, or when we do this, we're going to increase the success of any response. And also, it's just part of our mission as clinicians and civil servants of the city to do this, to apply this lens and this approach so that we are saving lives, which, we're grateful that all of you are already doing that, but it's important to remember to think about equity and in the way that you do your work, because it's going to increase your level of success. So now I'm going to talk about the community partner engagement unit within the Department of Health, right? And we follow what we want to call a whole community approach, right? And this all comes out of things that have happened in the past, emergencies that we've had to respond to in the past. And so just briefly, a little bit of history. For Hurricane Sandy in 2012, what the Department of Health and the city realized is that we were not connected enough with our community partners. We were not able to identify the right groups to go to or to support these community organizations who were doing the work ground on as Sandy hit. And so things fell through the cracks, right? And there was a need that arose out of Hurricane Sandy for the health department to be more aligned with our community-based partners, and not just the health department, but the whole city. So then we also think about Ebola. And so what happened in Ebola is that we did focus on targeted messaging. We did focus on communities who were going to be affected by stigma. And we did work to really create an equitable response in the Ebola response. And so we learned that working with our communities hands-on, we learned that tailoring messaging is really important and it is really useful. And that was also demonstrated in the Zika response. Initially during Zika, our messaging wasn't targeted enough, and so it wasn't impacting the communities who were at greatest risk. And the moment that we switched our messaging during Zika, we saw a huge shift in the groups who were at greatest risk in their ability to be able to protect themselves and their families from Zika. So it just becomes more and more apparent that it is imperative for city agencies and the Department of Health to really be aligned with our community partners. And so it's also part of a FEMA mandate, right? Whole community, right? It's a shared responsibility. Preparedness is not just for governments or providers, it's for everyone, right? If we're all going to be able to face this COVID-19 head on, we have to do it wholly. And yes, everyone has a different role, and that's fine, but we have to do it together. We have to talk to each other. It has to be bidirectional between communities and governments and partners. And so the community partner engagement unit was created a couple years ago, and our purpose is to sustain continuous bidirectional engagement with community partners during our ICS activations and connecting them with relevant operations and objectives across our response. We also want to leverage all of the existing relationships and resources we have here at the Department of Health to our external stakeholders, and to be able to help identify supports for our community partners. And we also want to be able to hear and learn the needs from those who are experiencing impacts, to be able to advocate and uplift any inequities that are being identified by our community partners. So the first time that we as a unit stood up was for measles last year. And we really wanted to support grassroots vaccine education and promote campaigns by our partners in impacted communities, which one of the most impacted communities were the Heredia families in Williamsburg. And we also wanted to mitigate risks of transmission and counter discrimination and stigma and fear for our at-risk communities. And we did that through our Emergency Partner Engagement Council, which is both something that works with our external partners and our internal DOHMA subject matter experts to come together and talk about what are the resources, what are the relationships that we need to increase, and how do we connect our work and our community's work together to magnify and amplify resources and solutions, and also to support our community engagement staff across the agency with talking points and materials to be ready to engage with communities as they are out serving. And we also wanted to track our community engagement so that we could identify successes and gaps and any additional inequities that we didn't identify during that our data would be able to show us what was happening. And it worked really well. We operationalized CPE and we engaged deeply and we advocated deeply and we created shared materials with the Haredi community that worked really well. We went out and spoke at fairs and we talked about vaccines and ways in which that community could receive. And it was a really successful experience for that community and for us at the Department of Health. And so in the case of COVID, early in the response, we wanted to mitigate risk of transmission and really counter discrimination and stigma and fears, specifically in the Asian American and Pacific Islander groups and immigrants. And so we created an anti-stigma task force, which really stood up and leveraged the fact that we as the Department of Health and other city agencies need to align on putting out anti-stigma language early on to combat the rise in incidences that the Asian American and Pacific Islander communities were facing with the rise of COVID-19. And we also went out and did listening sessions when that was still safe to hear what was on our community partners' minds, what were they needing, what was the information that they wanted, and we were able to outreach and educate and provide real talking points. And Dr. Ray, who spoke earlier, was part of this campaign to really talk to communities that were at risk and who are consistently at risk because of our social determinants of health and all the things we've spoken of. And we advocated up into the ICS structure about the things that we knew we were hearing from our partners so that we could leverage support early on and mitigate the disparities that were bound to happen because of how our systems are set up. And so we are still leveraging our Emergency Partner Engagement Council. In fact, it's only grown larger for measles as we are now in a pandemic, and so we need to connect to even more partners across the city. We are working very closely across the agency with internal staff, thinking through how do we, as we are in this mitigation phase, effectively engage with our partners and provide them with the most pertinent and useful messaging. And we are working to have the best messaging out for communities of color, specifically Black and Latino currently, but we are going to broaden our scope because this is a pandemic, and so there are many communities that need specific tailored engagement. And we want to, again, be tracking all of the work that we're doing as an agency to identify gaps and be able to be preemptive and less reactive as this response continues. So what is working right now? So I've already talked about our internal capacity, that we are identifying as many staff in the Department of Health who work with partners to expand and better our outreach to the partners across the agency. We have uplifted a COVID-19 equity task force to center equity in our response. And that is work that was connected through our CPU unit and uplifted. And as the agency recognized, this needs to be the center of the work that we do. We cannot ignore the disparities, and we have to make it our focus to create equity in this response, because our communities need it. And if we don't do it, there will just be more inequities as this response goes on. And so we are co-creating strategies across our response. We are talking to you all today, providers. We are continue to talk to our partners. We are also creating tailored engagement for Black and African American groups, the Latinx groups, the Asian and American and Pacific Islander groups, immigrants, and the LGBTQ, TG, and C group. We are specifically tailoring engagement for these populations and only hope to expand more, as we are fully aware that there are many groups that aren't being reached and accessed, as Dr. Ray brought up, particularly undocumented New Yorkers and immigrants. And so it is our special push for us to connect to these communities, to serve them and identify the resources that they need. And we've also made sure that our unit is staffed just as diversely as the agency is, which is why Nannette, my co-facilitator, spoke. She's from the Race to Justice unit, and I'm from the Emergency Management unit. And we have so many other units represented in the community partner engagement, because we know that it takes a diverse set of experts to really tackle these structural issues that we're facing right now. And we continue to actively track all of our engagements, our listening sessions, our speaking engagements through webinar, any surveys that, surveys we send out. We are really working hard to identify gaps and inequities through data, to support all the advocacy that we hope to continue to do, and also to create some real policy shifts as a result of this response. We're coming to a close, and I want to say thank you for allowing us to be here as a part of the provider presentation. We think it's important that this discussion is had amongst you all and us, so that we can think again, how do we as a city together respond to the inequities and work as one to really mitigate them, and just forward plan to keep mitigating them across the city. So I will stop now, and I think we are doing some questions.
So thank you to Dr. Ray, to Yeashea, and to Nannette for your presentations and all this important information. Unfortunately, we're right at 3 o'clock, so we won't have time to answer your questions live here via voice, but Dr. Mary Foote, our healthcare systems planning lead for outbreak response here at the New York City DHMH, has done an admirable job of answering the questions in the text in the Q&A chat box. And we will also make these slides and a recording of this webinar available on our website shortly following this presentation. You can also find recordings and slides from our past webinars on our website as well. So we will make sure to send out all that information. And we thank you very much again for spending part of your afternoon with us today. We look forward to seeing you next week, same time, same place, for our following webinar. And we will send out information about that very early next week as well. Thank you very much.